Alrighty, so just remind me of my time frame. I have 90 minutes reserved, but I want to make sure we include like question and answer and comment. Is that
Yeah,
correct?
yes. Usually we try to do it in an hour, but we just have 90 minutes. Just I think people start leaving around 12.
Listen, I got it. I got it.
Oh.
Just want to make sure I stay within that time frame.
Yeah.
Beautiful. Alrighty. Well, hi friends. If we have not met before, nice to meet you. If we have met before, great to see you again. I get to talk about one of my favorite topics ever today, which is looking at how we can address health disparities and health equities, particularly in primary care where people are showing up. So before I get started, I'll give you my spiel. I'm the Director of Research Health Equity and the Clinical Director of our Consultation and Training Program at Cherokee Health Systems in Tennessee. We have 19 brick and mortar locations and a mobile clinic who we affectionately call Big Bertha. And we're in 10 counties across the state. We saw about 70,000 patients last year. And we are really working to prioritize the importance of equity and addressing disparities as a system-wide initiative rather than just the quality improvement team. And so in the past year, we rewrote our entire mission and value statement, and it has a focus on equity, disparities, inclusion, belonging, dignity, justice. Like we got a pretty fancy new mission and value statement, like really proud of that. And we just officially launched a shared initiative with University of Tennessee, Knoxville. It is the first FQHC academic partnership in the country. Yes, we Googled. Yes, we searched. We wanted to make sure we could say first confidently. And our goal is really to promote research and education, as well as like program development, education, training, workforce development for areas of health with the goal of addressing health disparities and improving health equity among our community members. So when I get to talk about this, like it's not just, ooh, let me tell you what I looked up before we gathered. Like I get to live and breathe this. So if I get excited, just mind your business, or maybe you catch up some of that excitement with me. But either way, this is my jam, okay? What will we talk about? The basics. I always like to level set and talk about what I mean when I say words that I'm gonna say as we're talking. Doesn't mean it's the right way. It means that's what I'm talking about. So when you hear me say those words, you're like, oh, okay, I got it. So we're on the same page. Then I'll also give you what I call the framework that will guide the discussion that follows. We'll talk a bit about disparities, and we'll talk about some ways that we as behavioral health providers can help to address these disparities by working toward health equity, even in the integrated care setting. So if you've ever heard me present on this topic, you will have seen this slide and the slide that comes next, okay? And it's just bread and butter for anything when I'm talking about equity and disparities, okay? So let's start with disparities. Again, that's the topic of our conversation. Those are the actual differences that can be observed. So we know that between certain groups of people, there are better health outcomes compared to others. It is literally the observable difference that you can see, okay? When we think about equality, you're like, oh, we can get rid of disparities if we give everybody the exact same thing, because then obviously there won't be anything that's unequal anymore. Not so hot. And then we have the social determinants, which are those non-medical factors that contribute to the disparities. They lead to the differences in the outcomes that we see. And then, as you can probably tell, equity, the last one, the most important in my mind. Equity can be thought of as a process and an end goal. I think about equity as the root cause of the disparities, the root cause of the social determinants, or they represent the social determinants, which in time, which are then the root cause of the disparities that we see. So equity is either the process of identifying the root cause and or the end result, which means there is no more barrier. There is no more root cause that contributes to the disparities. So I think about it in a twofold approach. Again, if you've ever heard me talk, you've seen this slide, and I'm gonna do it again because it's one of my favorite ways to set the stage when we talk about things like this. This is the fancy baseball game metaphor. All righty, so I just like to set the stage. You can read it, but I'm gonna set the stage and give you a story that goes with it. It's not really that fancy, but we're good. So person on the left, we're looking at that left frame. It says reality. You know, every now and again, some people are born with resources, right? Like they didn't ask for it, they didn't give it back. So the best way for me to describe that is like being right-handed. Anybody right-handed on this call? Yeah, okay. So for those of us who are right-handed, I bet you, I'm throwing things. I bet you cannot recall a time when you had to take some right-handed scissors and like flip them like this so that you could cut with them, right? This is what a left-handed person has to do, like find that interesting angle so that way the scissors that were made for people who are right-handed could work for them. Again, if you are right-handed, I bet you can't recall the last time you had to change the buttons on your mouse. So that way your left hand really did what we might call the right click as opposed to the left click, because this mouse was made for those of us who are right-handed. Like it is for us. If you look at the way doors and things are made, typically the entry point is with your right hand, because again, the world was made for people with right hands. But if you were left-handed, it's not like you chose and said, hey, you know what, universe, God, power, whoever formed me before I was conceived, I would really love to be left-handed. Same thing with right-handedness. Like we didn't ask to be right-handed, but it doesn't mean we don't get the added benefit of having right-handedness. So in this reality slide, imagine the person with all the boxes as being right-handed. They ain't asked for those crates. They have them because they were born, okay? And that's reality. Some people are born right-handed. It is what it is. We can't change it unless we're gonna chop off our hands or try to reteach somebody how to work. You were born with the right hand. Deal with it. You can't give it back. There's nothing to be ashamed of. Yay, right-handed. And some people are born left-handed. So look at the person on the far right of that first panel. They can't even see that baseball game, y'all, because they don't even have a crate. They're born under, you know, the line. So like handedness, what is that? Completely left-handed in this picture. And if we're talking about equity as being, or social determinants as being things that like improve the way we live, work, breathe, and how we can align ourselves to have the most valuable and healthy lives. If the baseball game is the valuable and healthy life, who's the only two people who get to have that valuable and healthy life? The right-handed people, okay? The left-handed people don't even have access to the game. Equality is like, cool, let's just give everybody like, I don't know, let's just have everybody switch their mouse so that way the left is really the right or the right is really the left. Like, let's just make everybody like use right-handed things. Obviously, they will then be able to see the game. Life will be amazing if we just give everybody right-handed tools. No, it won't, because look, the person on the right still can't see anything. This is like their access to a healthy, fulfilled life. They don't have that because again, they didn't ask to be left-handed. They didn't ask to be short. They didn't ask to only get one crate. But if we think about equality, this is the equivalent of us giving everybody the exact same resource in the exact same amount. When you look at it, it looks kind of stupid when you look at it. Like we didn't really do anything. The first person who's right-handed is still right-handed. They are loving the baseball game. The middle person still right-handed, loving the baseball game. Person on the right is like, I sure wish I could see the ball, right? Equity is like, cool, I got you. Let's make left-handed devices for people who are left-handed. Let's give the person on the right 2 crates because they need 2 crates. The person in the middle, they could always see the game with 1 crate. So we don't need to give them anything extra. And the person on the left, guess what? Even if I take all your crates away, you can still see the game. That's equity, giving everybody the tools and strategies and resources that they need to address their individualized need, right? And that's all fine and dandy. Like it's absolutely amazing, beautiful. Everybody's looking at the baseball game. But if you've ever heard me talk, you know, I got a question coming. Why do we keep modifying, you know, like the resources and the supplies? Why do we keep like giving people crates to see over the fence when the real problem is the fence itself? Why don't we knock down the fence instead of trying to create boundaries around, over, under the fence? Like we're missing the problem when all we do is modify resources instead of addressing the barrier, the root cause, the fence. And so justice is when we knock that fence down. Okay, they are still in the exact same positions they were in as far as like right-handedness, access to resources, whatever, but we took the barrier away. And now they all have equal access to this full, valuable, pleasurable, healthy life, which can be demonstrated through the baseball game there. When I talk about equity and justice, I'm thinking about, the process. How do we pull that barrier down? How do we knock a fence post down, even if it's just chipping one splinter at a time? And I'm also looking at the end game, which is justice. What does it look like when the fence is gone? And so process and end goal, but this is how I shape and frame the things that we're going to be talking about as I move forward. That was a lot, I know, and we'll be fine. But as I stated, we oftentimes miss the real problem, which is the fence. We think about getting over the problem, getting around the problem, getting under the problem instead of knocking the problem away. And so let's talk about some disparities that we know about. Like, these are real facts. I pulled these from like 2022, 2010, but I also checked to make sure that the measurements hadn't changed since then. And unfortunately, the numbers are roughly the same from 2010 to 2022, 2019. Either way, let's look at substance abuse disorder. These are all things that in my role as a behavioral health consultant working in integrated primary care, I see these things every single day. Every single day, whether I'm specifically addressing substance abuse or not. People don't leave their substance abuse at the door when they come in for care for their hypertension or care for their depression. So I deal with it every day. If we do well child checks, we are dealing with infant and maternal mortality and risk and things like that. So every day I encounter these things. But when we think about it, let's look at some of the differences and outcomes in treatment. I'm not sure if everybody knows that methadone, while considered the gold standard for substance abuse treatment, is also the most highly stigmatized treatment for substance use, okay? Because it is actually an opioid itself. So some of the other medications are either opioid antagonists, partial, full opioid agonists, meaning they only cover a portion of the opioid receptor, so that way the rest of the opioid can't get up there, or they cover the full opioid receptor so no other opioids can get there. And that's where the cravings go away from. If you give the receptor what it wants, you don't have the craving. But methadone is completely different from those partial and full receptor blockers, okay? You can get addicted to methadone, okay? But guess who's more likely to get methadone compared to anybody else? The answer's up there: people of color. The most highly stigmatized treatment is also given to the people who have been oppressed, marginalized, and minoritized in the country, okay? Compared to white people, if we think about that in the United States. And Black and Hispanic women are less likely to receive treatment for opioid use disorder than white women. And Black and Hispanic people as a whole are less likely to receive treatment within 90 days of their discharge from the hospital following an overdose. What does that mean? They may go to the hospital with an overdose and they're like, peace, go find some aftercare. Whereas we know that in other groups of people, they will leave the appointment with an aftercare appointment. They will have a provider identified, or they may have the number of a peer support person who's like, I got you, I'm gonna walk you through this process. But we see clear distinctions and differences in how people are discharged from the hospital following the exact same event, a drug overdose, okay? Then we think about chronic conditions. When you think about who's more likely to experience, conditions like hypertension and diabetes, racial ethnic minorities in the United States are significantly more likely to have those disparities. It's quote unquote just a 10% difference, but y'all know that that can be ginormous. We also see that ethnic minority individuals are more likely to have cardiac concerns, cardiovascular diseases like hypertension, high cholesterol, cardiac disease, things like that. Pain management is one of those interesting things where consistently we see that people who are Black are less likely to get their pain managed. And it's because even within the last couple of years, they've done surveys with physicians, attendings, residents, interns, and like, hey, let's talk about some common medical beliefs. You tell me which ones you believe. They still believe that people who look like me, Black people, have thicker skin, which means we can tolerate pain better, which means you don't have to give me as much medicine, because if your skin is so thick, you shouldn't even be feeling the sensation anyway. So true story, y'all. Last year, and Alina and Sujina know this, last year I had a ginormous surgery. I am cut from my sternum down to my pelvis, straight down. My belly button is now an inch to the left of where it was because they had to go straight down. So I have a midline incision. And so I'm literally cut in half, y'all, right? I am in the hospital You know, I had to stay. They were going to keep me 3 days, but apparently I was too healthy. And so they kicked me out in 2 days, which is okay. They didn't want me to get COVID or anything like that. But my husband and I, who was there with me the whole time, had real active conversations because they came in and they said, what's your pain level? And so they give you that 0 to 10 scale. And I'm like, I don't know. I've never been cut in half before. I don't know if this is a 0 or a 30, but like, I don't know. And so I was like, 4. Because again, I didn't have an anchor. I've never been cut in half before. I can't compare it to anything. That pain scale was so arbitrary. I didn't know what to do with it, right? And then they were like, okay, we'll just keep you on the medications we have you on. And then my husband and I were like, should I lie? Like, if I say my pain is a 2, are they going to think it's because I have tough skin and because I'm Black? Like, should I lie? And then we were like, yeah, let's try it. And we purposely started elevating my pain level to see how they would respond. And plus, I didn't want to reinforce a stereotype that Black women have thick skin. And in the midst of my healing, I'm wondering, what stereotype am I going to reinforce and perpetuate based upon my honest response of the experience of my pain? So I started rating it higher than it was, even if I wasn't in pain. I didn't take the medicine, but I'm like, yeah, it's an 8. You want any extra medicine? You can leave it here. I'll take it if I need it. They gave me a morphine pump. I used it twice in 24 hours because it knocks you out as soon as you take it. I didn't need it. But like, we refuse to support the stereotype that Black women have thicker skin, therefore they don't need as much pain control. And when we think about it, we were like, we really had to do that in a hospital where I got 35 staples in my abdomen, trying to figure out how I respond to my pain is going to influence how they treat other people who look like me in the future. Like, that's a heavy load right there. And I've spoken to other Black women who have also had similar experiences. Like, do I really tell the truth? Like, do I reinforce that? But these are the stereotypes that contribute to the disparity. So when the stereotypes that people in the medical field still believe to this day are influencing how they provide care, then yes, there's going to be a disparity because there's going to be a difference in the type of care that's offered for one group versus the other. Okay. And then finally, the last disparity I'll highlight is the infant and maternal mortality. That thing is rising exponentially, y'all. It is out of control. A 2020 study, if I'm not mistaken, 2019, 2020, found that Black babies born to Black doctors are less likely to die compared to Black babies born to non-Black physicians. If I'm not mistaken, it's like a really disgusting number, like 40% less likely to die. Okay. Yeah, embarrassing and frustrating. It was, so the initial study was 2010, but then they redid it and showed it in 2020. It came out during like COVID when everybody was like doing things. But the disparities, it is out of control. The difference between mortality rates between groups of newborns. It's not as astronomical as among Black people, but we see that the rates among Hispanic pregnant people are growing exponentially. Okay, but because it's not as great as the mortality we see with Black birthing people, it's not getting the attention that it deserves. You can look at some of these, rates right here, like Black women, 40.8 per 100,000 maternal deaths, compared to 12.7 per 100,000 for white. Like, that's scary, y'all. Like, really scary. Okay. So what explains them? Well, we talked a little bit about like stereotypes, right? And how like, excuse me, we teach things that we've been taught and we don't always question them. You know, a lot of our healthcare system is, well, that's what we've always done. Well, I learned to do it this way and it's worked for me this far. So we're kind of perpetuating things like that. But stigma is a big reason why we see disparities. Talked about the methadone disparity. Whatever your beliefs might be about the role of substances or addiction, depending on who the person is, that's going to influence maybe what you treat. Excuse me, y'all. History, I'm gonna give you a history lesson on the next 2 slides, so hold on to that. Transportation can lead to disparities. How many of our patients have transportation difficulties? Right? They may arrive 15 minutes late. which means their visit is going to be shorter because you got to prioritize like the first thing. And that's if they're seen that day, because some people have policies. You arrive 15 minutes late, you got to reschedule. But if you're consistently dealing with transportation barriers, you're consistently arriving late, and you're consistently being faced with a policy that says because you didn't get there on time, because you didn't have your own transportation, you had to ask somebody to pick you up, or you waited at the bus at the right time, but the bus was 30 minutes late, you can't get your health needs met today. No wonder we see disparities, right? Like something as simple as transportation has that upstream concern that absolutely has a downstream effect. And so these are policies and things that I love that book, Under the Skin. Thank you, Kendra. Read it. It was amazing. I second that recommendation. Access to care. The clinic I'm in right now, I have books lined up on my windowsill. And I always like to say that if I did not have those books, I'd be looking in my neighbor's window. Like that's how close we are to the community. We did this on purpose. Like brought the clinic here on purpose. We did needs assessments to see if the community would invite us or welcome us here. But they were like, we don't have a doctor that's close. So we're here in response to community need. But how many communities don't have a community health center? Even though we have this community health center here and my neighbor's window is right past my books, the closest pharmacy is a 10-minute drive or an hour-long bus ride, or about a 2-hour walk, depending on the pace at which you're walking, any disabilities you may have, any pain you may have, any asthma you may have. There is no pharmacy in this neighborhood. So when we hear patients say, no, they didn't take their medicine, did we ask, were they able to get their medicine? We assume they're just choosing not to take it. We don't know what's going on. Gaps in knowledge. We don't know what we don't know. Cultural beliefs. Like, do people have jobs? When I think about like employment, and I think about some of the legal implications, right? Like we think about somebody who may be experiencing or going through recovery for substance use. And one of the legal requirements is that they attend like addiction counseling, and they have to work to demonstrate that they can, return to a functioning level in society, whatever that means. Then they have to pick and choose, like, well, do I go to my treatment or do I go to work? Do I get a nighttime shift that's going to make me more likely to encounter the people that I used to use with anyway? Or do I just not work? Do I risk going back in jail because I'm trying to find a way to work and attend a class that only works around the provider's schedule, not my schedule? We had to switch our whole addiction treatment model because requiring someone to come in 3 times a week for 3 hours a day and still meet their probation requirements and still work and still try to be a family, family oriented. It wasn't fair. It was convenient for us. 2 to 5 p.m. Great. That works. I can go home as soon as I'm done. But not everybody who needed that service to fulfill their requirements could make all the flexible adjustments that we were requiring them make. So we flipped it on its head. We now offer a longer duration, but 1 day a week, 3 hours, and it doesn't start to 5 o'clock. So people can go to work. It's more likely that they'll be able to leave 15 minutes early 1 day a week than skip 3 hours of work 3 times a week. And so a lot of people report that that's helpful for them. And the judge for the drug court nearby has signed off on it. It said it meets the requirements. And so we have community partnership with that, right? So these, again, I'm just highlighting a few of the things that lead to the disparities that I talked about. But here's the history lesson I promised you. Here's some other causes of disparities. And I'm going to be frank that with the exception of The Immortal Life of Henrietta Lacks, the books that I'll show you are written by people of color. I am a firm proponent that we need representation when we tell stories. And so all these were intentional, okay? But when we think about causes of disparities, hopefully everyone has heard, or you're going to learn today about gynecological horror that was inflicted upon mostly enslaved women and poor Irish immigrant women. But the person who was called the father of gynecology did all the experimentation on enslaved women and then Irish women without anesthesia. And that's how, for those of us who have like a vagina or a cervix, that's how we came to see this lovely Pap exam. It was perfected on these bodies without anesthesia. And I don't care what you tell me, I'm gonna feel more than just some pressure when you give me a pap. I'm just gonna be real. It does not feel good, okay? But that's how we know that. That's a disparity. So when they're inserting things into the bodies of people who are Black and brown without anesthesia and they don't pass out and die, then obviously their threshold is higher than anyone else's. Because look, but did they die? No. And we figured out how to do pap exams. Wow, every person of color must have that threshold. That's the cause of the disparity because the stereotype is embedded right there. I don't know if anyone's ever heard of a Mississippi appendectomy, where Fannie Lou Hamer, she was a civil rights activist from Mississippi, and she went in with complaints of appendix pain. So they're like, cool, we're gonna give you appendectomy. Beautiful. She wakes up without a uterus, y'all. For appendicitis. So we think about people delaying care, delaying access to care, refusing, if you will, or declining surgical procedures. These are some of the reasons why. Like, we got real life stories of people who went in for one thing and came out with something else missing. We know what we know about things like Depo-Provera because we tested it on Black and Latina women. Right? Like we said, nope, you can't have babies, the end. So we're going to test out Depo-Provera on you. And we found out Depo works because we gave it to people without their consent. Then, of course, there used to be court-ordered implantation of Norplants. Like, we're going to control your bodily autonomy because you're in prison. I'm going to avoid anybody who is affiliated with that if I can help it, if that's the history that I know. We all know about the communicable diseases at Tuskegee, the U.S. Public Health Service. They allowed 400 Black male sharecroppers who were infected with syphilis to go untreated. But you know what they gave them? Burial insurance. We knew that, penicillin was the cure for syphilis at that time. But instead of offering it, we wanted to see the natural progression of syphilis in the Negro male. That's what it was called. But we made sure they got buried okay. Okay, so these are other causes of the disparities, this historical piece. We got long memories, y'all. We all know about Henrietta Lacks. I hope you do. The book on the left was written by Rebecca Schlute, and she did almost an ethnography where she embedded herself in the family of Henrietta Lacks, whose cervical cells were taken and placed in a petri dish. And then we know what we know about a lot of treatments in cancer because of Henrietta Lacks' cells. She's the reason why we now sign those consents when we go in the hospital that says you understand that any pieces of your body that we take out, we can use for science and teaching and blah, 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 blah. Before her, that was not part of the informed consent process. The book on the right is one that most people don't know about. It was written by her nephew, Ron Lacks. It was published this year, and it coincided with the news that her family actually received a financial settlement in August of 2023. It took from, I think, 1960 to 2023 for their family to be compensated. Henrietta passed away. She never benefited from the work that her cells contributed to, but her family finally got some compensation for all of the money that, medical and pharmacy has made off of their family member cells. And here's some that really apply to what we're doing right now. Yep, the forced sterilization of the Native American communities, all that mixed up in there. Here's some of the more common ones that I had to learn more about. But so nephrology, when we think about dialysis, ideally we shouldn't be doing this anymore, but I've seen it in some medical records. But there was this belief that Black people had more muscle mass than white people. There was a belief that they had lower body fat, higher total potassium and calcium, and higher creatinine, which is the marker that shows the kidney functioning. And so they were like, because we got all these beliefs, we are going to add a multiplication factor to the measurement of kidney functioning, the eGFR, so that the functioning looks like it's doing really good, because we got to account for all this extra fat and all this calcium, y'all. So we're going to add a multiplication factor. So if all other things being equal, somebody's eGFR, I'm going to make up a number, y'all, is a 7. The person who's white keeps the 7. the person who's white, who's Black, is going to get it multiplied by like 3.5. So it looked like it's 21.5. Your number has to be below a certain threshold before you qualify for kidney treatment. Has to be below a certain threshold before you qualify for dialysis. Has to be below a certain threshold before you qualify for a kidney transplant. So if we are elevating the functioning of a group of people, what do you think is happening to their health, to their mortality, to their morbidity, to their quality of life, to their access to care? We are delaying access to life-saving treatment because we erroneously multiplied by some random factor that accounts for fat and calcium. It's not true, y'all. Like, there is no difference in that way. But we're still seeing the fallout of the years and years and years of the factor being added on. I don't know if anybody ever looks at labs, but if you look at labs from like maybe even 2 years ago, it'll say if Black, adjust this way, and it'll give you that factor that it adjusts by. So it increases, it overinflates the functioning of the kidney. So it makes it like Black people are doing way better than they are, which means they can't get the treatment that somebody else would get because we've added some random number to their care. So obviously disparity, right? Clearly we have more people likely to have diabetes and kidney disease if they're Black compared to other groups. That is a direct cause of the disparity because we're withholding care from them based upon an erroneous belief about their body type. And spirometry was the one that I was like, what? I got this book right up here. It's called Breathing into the Machine, okay? But when you think about spirometry, that's that little thing where they measure like how much volume your lungs can hold. They use these spirometers to measure the capacity for Black soldiers. And they were like, y'all, Black soldiers have inferior bodies. They can't even hold oxygen in their lungs. And they were like, white soldiers have a higher lung capacity. So they also developed a race correction factor to interpret the lung functioning test. So it made it seem like Black soldiers were doing better than they really are because they're so weak. We're going to give them a little boost, right? Like, so that way we can really look at it. So that also means delayed access to care. We still see disparities in asthma even to this day. If we're looking at racial and ethnic disparities, you're still seeing them to this day. And it's because of the measurements that we use consistently to determine their functioning have been like jacked up and messed up from the beginning. And even if they are making corrections now, we still see decades of harm. And when they show up to us in integrated care, they have these disparities. And these are the things that are leading to the disparities that lead them to us. And so when we finally get a chance to see them, we got decades worth of harm that we're dealing with. Okay. So that sounds real dreary, right? But we got to do something about it. Like, remember I told you, I'm tired of building crates around the fences. I'm tired of like, like spreading the fence apart, or I'm tired of like taking crates from one person and giving to the other. I'm tired of that crap. I want to see some fences break down. I want to see some fences fall. So part one for me, how the heck do I move the fence? I need to know about those things I just told y'all about. Some of y'all may not have known about the kidney multiplication factor or the lung capacity multiplication factor or Depo-Provera. You may not even think about the social determinants of health, which are those environmental, non-medical factors that might make it harder for your patient to even make it into the door of your clinic for you to help them. That's the context for these disparities. That's step one for knocking down fences, okay? Other fences are us, y'all. We can be a fence post. It can be us. If we refuse to learn and pay attention to the things I just gave you the quickest summary of, you're a fence post. If our default response is, well, they no-showed the last 3 appointments, I'm not going to see them today either. Raise your hand if you said it. I'm calling myself out. I have had thoughts like that, okay? Like, they ain't coming. And then they show up, you're like, oh, hey, didn't expect you here, right? But like, we've had thoughts like that. Let's just pretend we're human for 2 seconds. We have thought things like that, but that makes us fence posts. We become barriers to our patients' wellness. We think about things like the competence. So again, knowing the history, knowing the decades long exposure to harm or the failure to provide care that a lot of our patients bring with us, that influences how we provide care. Some of us and I'm using the us very loosely, have a one-size-fits-all approach. Well, this is how I treat everybody with kidney disease. This is how I treat everybody with asthma. This is how I treat everybody with depression. This is how I treat everybody with anxiety. But y'all know that's not the case. Not every person is exactly the same. Even when we think about idioms of distress or the way we describe distress, that's not the same from person to person. We provide care to refugees here on Thursdays, and I learned real fast that there are some languages for which the word depression does not exist. So I can't ask you about being depressed. I can't ask you about being sad because those words don't exist. I have to ask about your heart. How's your heart? Not, are you feeling chest pains? Right? Like, but does your heart hurt? That's getting at the emotional part that connects to like the sadness. You can even contextualize it like, does your heart hurt when you think about the family members that aren't here with you? If they tell me my chest hurts, I'm stepping out the room and tagging in like a nursing colleague, like, hey, friend, they said their chest hurts. We weren't talking about heart. They said chest. You need to come in because that's not, I'm not going to be assessing like chest pain and things like that. But knowing that culturally, we need to understand that language varies according to where we come from. And the way we talk about distress is going to change. So we can't be like, I asked you about depression. Like, I don't know what this heart stuff is. Like, are you depressed or not? Yes, I've heard bad things like that. When I give like impressions, it's probably because I heard it. Okay. And which is really embarrassing, but I've heard lots of things, seen lots of things. But like, no, I asked if you were sad. I didn't ask about your heart. That's them telling you about their sadness when they tell you about their heart, but us being rigid and not being willing to understand and learn more. Okay. Communication. We see that the time spent in offices, certain providers talk more than they listen, depending on who the patient is. Some providers listen more than they talk, depending on who the patient is. So you can imagine that if the provider is talking more than they listen, those are the individuals who may be more likely to have disparities. That applies to us too. How often do we listen compared to going and direct and try to tell somebody what they need to do to stop smoking? As opposed to asking, what are the benefits of smoking for you? What are some of the not so good things about smoking? How can we work together to make a plan that works for you? Right? But when we talk rather than listen, we're supporting disparities. We are building fence posts. Okay. And comprehensive, again, we don't do as much for people who have been minoritized, marginalized, disenfranchised in the United States. Data tells us consistently that they're less likely to get the specialty referrals. If they get them, they're significantly delayed. It could be due in part to things like eGFR and the spirometry measures. Could be that. It could be due in part to the fact that I had to lie about my pain level because I didn't know what stereotype the people had. We don't know what that causes, but we do know that they're less likely to get the higher level of care as soon as other groups might get. Disparities, okay? So I'm gonna pause for a minute. Use a chat box for me. What fence posts have you noticed in your healthcare setting? And snitch on yourself if you have to, because sometimes we are the fence posts. So think in terms of policy, procedure, staff. Those are typically some fence posts that I see both internally and when I go to other organizations to do consultation. So I snitch on myself whenever I get a chance. So as you're generating these, still put them in there. Good, good, good. Providers not seeing patients if they're 10 minutes late. That breaks my heart, y'all. Like really breaks my heart. Medical providers not acknowledging or even noticing different economic levels and how this impacts care. Yep. Giving medications without asking, like, can you afford this? You know, like I've seen some things like where I'm like, you got to work with them. Like they can afford 7 days worth of medicine. Can you prescribe 7 days and they'll come back and again and get the rest of it? Like, does it mean they can't start because they don't have all the money today? But yeah, these are some fence posts. Again, I snitch on myself whenever I get a chance because, you know, even though where I work is known for doing a lot of integrated care stuff, we are still an organization that has flaws. I have a Robert Wood Johnson Fellowship, and I'm partnered with 2 colleagues from University of Tennessee, and we're looking at the effect of racism on health outcomes among patients who receive care at FQHC, because they are not exempt from experiencing racism just because we're in FQHC. And another portion of it is looking at the policies and how the policies, like our operations manual, how that contributes to any disparities or health outcome disparities that we might see in our patients' health. Staff not recognizing the importance of trauma, becoming complacent and have to be reminded that if it were us or a family member, yes, talking at and not asking what will work for the patient or the family. That is so important. Like, would you want your family to receive the care that you are providing? And if you wouldn't do it for your family, you better not do it to that patient. Or if your colleague, if you wouldn't trust your family member to be treated by your colleague, then you need to check your colleague. But we're doing interviews with staff and with patients, y'all, to get at the root cause. Like, what are we doing as an organization that could be contributing to disparities? We want to know. And it's painful, y'all. Like, reading some of the interviews and the transcripts, it's painful. It's painful. And it's those people's lived experience. And it's a reminder that we got some work to do. Okay. That's part of that competency piece. Like, a fence post is refusing to accept that you need to grow, refusing to accept that there is room for change, refusing to accept that what you did may not be acceptable by the patient. Just because you did it and you have a degree behind your name doesn't mean that you get to not pay attention to the patient's values and needs. But these interviews are painful, y'all. I'll give one scenario, like, and I think this is common. There is a patient who was having lots of challenges regarding like menstrual bleeding and things like that. Came in and saw a provider who was like, it's because you're stressed. Let me give you birth control pills. This went on, this went on, this went on. The person ended up having like ginormous fibroids in their body. And as soon as the fibroids were removed, the bleeding stopped. And so they felt silenced, unheard, dismissed, disregarded. And I can't tell you, like, that's the only story we'll hear like that, even at home. That's a fence post. Not being willing to think about something beyond what our first gut tells us. That's a fence post. Okay. Lack of diversity in staff, lack of bilingual staff. That's a preach. No one who looks like some of the large populations of patients we see, medical providers who are hyper-focused on medication non-compliance. I'm so glad you put that in parentheses as an intentional behavior and choice, because again, we don't know about resources that contribute to that. Struggling with developing appropriate boundaries regarding workplace violence, specifically patient to provider threats and verbal abuse that consider mental health disparities, but also protect staff. You know, that is so hard. And I'll refer to the person who said, Beth said, staff not recognizing the importance of trauma-informed care. Every new person who enters into our healthcare system is trained on trauma-responsive, trauma-informed care. Essentially, when we encourage people to say what happened to you instead of what's wrong with you. So we start at the beginning with that. And we recognize that, like, nobody wants to be threatened. I don't care how professional you are. Like, if you scream in my face, you're going to get like Ebony, not Dr. Winford. Okay. And just to be real, like my mama said, you don't start fights, but if someone starts with you, you better finish it. Ebony will finish it in some form or fashion. I'm just going to be real. So we can't act like we're not humans just because we have degrees. Okay. So we want to teach them about trauma responsive, trauma informed care. And we got to teach skills about how to de-escalate. And the one thing I tell anybody I supervise, being afraid, being scared, being harmed is not one of the competencies I'm going to evaluate you on at the end of the year. You do not have to take that. You can walk out of any room you want to, as long as you have a path of egress, and we're going to set up your room so you always have a way to get out. You leave. You do not have to sit with violence, whether it's verbal or physical. That is not a part of your competencies. That is not going to get you a raise. It's not going to let you keep your job. You leave. And if you don't feel safe doing it, You send me a text, you send me a message, I'm just going to walk through the door. You can ask my team members, like, we use Microsoft Teams. And there have been a couple of occasions when a team member's like, help in room 3. Some people are like, oh, what do you need? How can I help you? I literally walk in the door. Hey, you need anything? Like, I'm busting in, because psychological safety at work is so important. That's part of the trauma responsive part. You got to know that you don't have to be harmed to help somebody else. Yes, people come in with lots of trauma, lots of baggage. It's still not okay to act on that trauma and baggage. You can say, listen, that's not cool. I will take care of you as long as XYZ. I've said to people, I'm gonna step out and give you a few minutes because right now I'm feeling upset and I want to be able to listen to you. So I'm gonna step out. I've had people lose their minds and throw things up. And I'm like, guess what? I can't take care of you today. I'm gonna ask you to leave. We have security in a lot of our offices. I'll be honest, flashlight cops. I don't care, because they don't have weapons, thankfully. But I might tag one of them in and say, I need your help escorting this person out. We can't take care of them the way we could today. We need to ask them to leave. So be okay with recognizing your humanity. I think oftentimes as like FQHCs, especially places that provide care to low-income patients, we think we have to take so much more. You are a human first. And you can practice compassion while still being safe. And so I'm like, you leave, you can tell me, but you being afraid is not part of your job description. We're not going to do that. And I think you have to have the autonomy to do that. I'm thankful that I have a leadership that supports me saying, nuh-uh, what we're not going to do is talk like that. And I'm not going to get fired because I check somebody or somebody checks me. I think that's part of the culture. Really long answer to you, Lana, but like, it really is, what permission do you have, if you will? What permission do you give? So when we're trying to figure out how do we knock down the fences, I'm gonna give you a very brief description of like how we've been using data, UDS data, to identify disparities, but then also knock down the root cause, the fence. And then the huddles, we do morning huddles every day, and we look for people who have what we call gaps in care, who's available to take care of the patient in the moment while they're here, because I don't know if we realize how many hurdles and barriers we introduce when we ask a patient to come back for a service, right? Like, come back tomorrow, come back in 1 week, instead of such and such is here right now. If you're willing to wait 15 minutes, they'll come take care of you today. So we talk about things like that in our huddle, because a barrier is asking somebody to come back for 3 appointments when you can take care of it today. A barrier is the reimbursement procedures that you have to advocate for so you can get same-day billing of more than one discipline. That's a barrier. We've had to fight to get that barrier down. We got to make sure we expand our scope of practice, particularly as BHCs. You cannot only treat depression, because if you can tell me somebody who only has depression, I will find $1 million for you. Okay. In a health setting, you will not find somebody with only depression. So you can't just treat depression. You got to treat anything that walks through the door. And we can't just refer everything because we've never seen it. You push pause, step out, go talk to a colleague, go look at Dr. Google or something reputable, and come back in and say, okay, so I don't know much, but here's what I know. We're going to start here. Okay. We can't just refer people out. That's a barrier. We give education to patients, and we can also inquire about patient preference. We can prioritize their needs. That is a way we build stronger relationships. We check ourselves, our biases. These are all ways we kick down defenses. Tiny things that have ginormous impact. Now, this is something that I'm proud to say I requested, and now it's being implemented. But when I became the director of research and health equity, I was like, can you tell me more about the data? Like, we get UDS metrics emailed to us every week. Like, leadership gets a summary of this every week. So it tells us how are we doing on the key indicators that we have to report to HRSA. And you'll notice how intelligent and how fancy this coding system is, but we use red, yellow, green to tell us how close we are to meeting the HRSA metric. So green, we're doing amazing. Yellow means we're literally at the goal, or slightly under. Red means we're on the struggle bus, okay? But for a minute, we were literally just looking at the aggregate of all these indicators. So I know you probably can't read it, but we got BMI, adult, breast cancer screening, Pap exam, immunization, colorectal screening, depression screening, diabetes management, hypertension management, low birth weight. Those are what's across the top. But we were just giving the summary, like how close were we as an organization meeting these goals? Then we did by clinic, right? We did by region, but we never did by identity marker. So like this, we got people of different races and ethnicities. We assumed that everybody was the same when we looked at the aggregate data that way. So I requested data disaggregated, meaning broken up by the different indicators of identity that we have in our chart. And that's when you start seeing some patterns emerge. Okay, because before, if everything looks green, you're like, yes, we're doing an amazing job. But I don't know if y'all can see this right here. This 80%. I don't know if y'all see like the blue bubble going around. Okay. Yeah, that's the only red one, y'all, in the low birth weight. Guess who that is? When we look at it aggregated, it was green. When you break it down, we got one group that's 11 percentage points behind. That's a disparity that got masked because we looked at things as an average. I dare you, if you have any power, to work with your team to get data. Even as a BHC, you can use the data to start kicking down fence posts. We missed that until we got it disaggregated. We thought we were doing amazing. There's a group of people in our system who are not doing amazing. We developed a coalition within Knoxville, Black doulas, Black birthing workers. And now we got our numbers like up to like 93% now, because in response to seeing the data, we made a plan. And we started making sure that BHCs became more involved in the prenatal visits, started giving more education about, you know, like signs and symptoms of preeclampsia, which we know contribute to low birth weight. Like we made a plan in response to the data. We didn't wait for the top to say, here's our new initiative. We saw the data and we saw a gap. And so if you have power, if you have any influence, ask for it and see if you can start making some changes that way. This is one broken down by homeless status, right? So we see that like people who are doubling up, they're doing okay-ish. Then look at people living in the shelter that has the most red. That makes me want to know, are we gathering the data correctly? Right? Because if you're in a shelter, are we entering the right address? Like, how are we classifying you? What are the conditions of the shelter? Are you getting access to food? Can you store your medication? Right? All of this. This info is pulled from our EHR, our community, our health informatics team. Let me just brag on them. They are in boss mode, beast mode. They are amazing. They've created their own data warehouse, created our own data dashboard. They've created reports for me such that all I got to do is go on an internal server. It's called Web Reporter. I click a button, I can have data from any metric that I want in like 3 seconds. And I'm a data person, y'all. Like this stuff makes me happy because I can take historical data. I can take numbers data. I can take what I see with my eyes and communicating with my team to say, what can we do to knock down that fence? And a lot of people are like, well, I'm just a BHC. Notice how y'all have probably encountered somebody with kidney disease. You probably encountered somebody with asthma. You probably encountered somebody with pain. You've probably encountered somebody who was pregnant. Just because you don't routinely diagnose somebody as having asthma doesn't mean you can't take these conceptual things into context when you provide an intervention for them. So you might ask differently. Here's some things that some people find helpful when they're trying to stop smoking. X, Y, Z. Any of those things appear to be helpful for you? I've learned to ask, do you live in a neighborhood where you got a lot of corner stores? If you look at the data, y'all, geospatial data, there are significantly more corner stores per square mile of communities that are Black and brown compared to communities that are white. And you know what you can buy at corner stores? Cigarettes and alcohol. When I'm talking about weight management, walking is absolutely amazing. I might say, do you live in a place where you feel comfortable walking outside? As opposed to, you know what you need to do, go walk outside. These are things that you keep in your mind as a BHC, because if we just start giving people information without considering their context and their history, we're going to contribute to the disparity because they're not going to do anything we talk about. So this applies to us. Even if you never diagnose diabetes, you manage the behavior change associated with diabetes. Maybe you will now ask, if you're living in a shelter, do you have access to a refrigerator to store your insulin? You didn't diagnose it, you didn't prescribe it, but as a behavior change expert, you're going to ask about it. That's how we as BHCs take all this knowledge I just threw at you in 52 minutes, and you work toward providing care for our patients, okay? So I know we typically stop around 2:01 your time. It's right there on the hour. I have time to take questions, comments, concerns. If you need to slide off, my feelings will not be hurt. I will make sure you get a copy of this presentation. But I just want to empower you all to think beyond. Okay, I don't care if you didn't offer the diagnosis or prescribe the medication. Take some of the stuff we mentioned today, kind of hold it in your head and let it inform how you ask questions, how you problem solve, things like that. All right. So questions, comments, concerns, run away, all is okay.
I just had a question about the study you mentioned that you're doing, and when will that be done, and how will the results be shared?
So cool. I'm so glad you asked. It's a 3-year fellowship. So just entered fiscal year 3. And so it'll end next October. However, we have 2 publications under review right now. One of which I'll share with you. If you're a data person or done any type of research, you may have heard of like saturation when you're doing qualitative data, meaning you keep interviewing people till you hear the exact thing over and over again. So that's how you know you need to stop. You're not going to get any more information. We just submitted a paper on negative saturation, meaning we had people say, I can't do this anymore because they keep saying bad things like the N-word and verbally being violent to me. I cannot do another interview. I don't feel safe doing an interview. Because we have Black research assistants, we have white research assistants, we have Latinx research assistants, but our Black and brown research assistants said, I don't feel safe interviewing these people anymore. So of course we stopped. We didn't need more information from the patients. There was the saturation. They were afraid. Why would we keep putting them in that position? So that paper is under review right now. We have a paper using something called CARDIS, which is the critical race analysis something scale to review policies. One of my team members developed that. It's a published instrument. And we are literally going through every single policy that we have at my organization and looking at it through the lens of that tool. So to see, you know, are there any policies that could be contributing to this? That's under review right now, so you'll see that. But the biggest outlet is that we want to release a playbook for FQHCs who may have additional interest in making changes like this or doing needs assessments in these ways. So we've been journaling since we've been meeting in 2021. We meet every week, 2021. We have 6 research assistants, 3 PIs, and we journal, just little thoughts. But we're holding each other accountable, and that those journals are going to become part of the playbook. You're not going to get just the good stuff. You'll get like the places where we struggled, you know, places where we thought we were going to do this, but we were wrong. But our goal is to give it to FQHCs who are also taking care of patients like we take care of. So multiple dissemination methods. And we have a community, like a patient advisory board, who will help us determine the best method of dissemination among patients, because we can't take from them and not give back. Equitable. But I'll put my email address in here if you like have follow-up or questions or anything. All right, friends, I think they're like tired. They're over it.
Just to make sure, did you get a chance to answer Julie's question about is the Stanfield pulled off of EHR?
Yes. So that's where I was saying they built the
right.
reporting system for me, but it is literally, so I'll rewind. Our data warehouse consists of health information exchange network data, So from the hospitals that are part of that, we get it from claims data, and we also get it from electronic health record entry. And so it goes into this like fancy warehouse, and then it spits out into stuff that actually makes sense to me. When it's in that data warehouse, I don't know what it's doing, but when they spit it out to me, I'm like, oh, that makes sense. And so it's from multiple sources, but those are the three main ones.
So the goal is to get really cool IT people.
Listen, if they ever quit, we gonna fall apart.
Yeah.
They are the backbone.
All right. So I don't see any more questions, and it is 1:05. So I just want to thank everybody for joining us today, and thank you so much, Dr. Winford. We'll send a follow-up email after this. It'll include the slides, the application if you're interested in our behavioral health consultant certificate program, and also an evaluation survey so that you can take that. And remember, you have to submit that to get your CEUs. But other than that, happy holidays, everyone. I'll see you next time.
Bye, y'all. Have a great day.